In this video, we will discuss entropion. Entropion is inward rotation of the eyelid margin resulting in lashes rubbing against the globe. Chronic mechanical trauma from lashes causes progressive corneal pathology if untreated. The common effects are foreign body sensation, watering and redness, corneal epithelial erosions, pannus formation and ulceration in severe cases. Classification is based on the underlying mechanism producing inward lid rotation. It is classified as involutional, cicatricial, spastic, and congenital entropion. Involutional entropion is commonly seen in elderly patients and is caused by multiple age-related anatomical changes. Usually, it affects the lower lid and is the most common type of entropion. The pathogenetic factors in involutional entropion are horizontal lid laxity due to stretching of canthal tendons and tarsal plate, vertical lid instability due to attenuation or disinsertion of lower lid retractors, overriding of the pretarsal orbicularis muscle, orbital septum laxity with prolapse of orbital fat. These factors act together, tipping the lid margin inward towards the globe. The clinical clues in involutional entropion are entropion worsens on eyelid closure, improves with downward traction on lower lid, and reduced downward excursion of lower lid on downgaze. Temporary measures protect the cornea but do not address the underlying cause. Lubricating eye drops, tapping of eyelid, soft bandage contact lens, and botulinum toxin injection into orbicularis muscle are the temporary management measures. Definitive treatment must address all contributing anatomical defects to prevent recurrence. Correction of orbicularis overriding, reinsertion of lower lid retractors, and correction of horizontal lid laxity. Everting sutures provide temporary correction and are often used when definitive surgery is not immediately possible. It prevents overriding of the preseptal orbicularis and is a quick and minimally invasive procedure. It is useful in frail or uncooperative patients, and the correction lasts several months. The Weiss procedure gives a durable correction. It consists of a full thickness horizontal lid splitting and insertion of everting sutures. The everting sutures redirect the pull of lower lid retractors. The scar creates a barrier between the preseptal and pretarsal orbicularis, and the everting suture fairly effectively transfers the pull of the lower lid retractors from the tarsal plate to the skin and orbicularis. The lower lid retractor reinsertion procedure involves direct exposure and advancement of the retractors, as opposed to less precise approach used in Weiss procedure. It may be primary or reserved for recurrence. Horizontal lid laxity is usually present and can be corrected with a lateral canthal sling or tarsal strip, or less commonly with a full thickness lateral pentagon. Tightening serves also to retain the lid in a position against the globe, preventing overcorrection. Cicatricial entropion is due to posterior lamella shortening, pulling the lid inward. The common mechanism is scarring and contracture of the palpebral conjunctiva, which is caused by conditions such as trachoma, cicatrizing conjunctivitis, chemical injuries, trauma, and chronic inflammation. The clinical features of cicatricial entropion are conjunctival scarring, distorted lid margin, often associated with keratinized conjunctiva. Unlike involutional entropion, lid laxity may be minimal in cicatricial cases. Management is more complex and directed at correcting posterior lamellar deficiency. Temporary measures are similar to involutional entropion, and definitive surgery is based on severity. The surgical options are tarsal fracture with anterior rotation of lid margin in mild cases. Severe cicatricial entropion requires reconstruction rather than simple lid repositioning. It involves replacement of the deficient conjunctiva and composite grafts. Some exam relevant points are: the most common type of entropion is involutional entropion. Key mechanism is orbicularis overriding and retractor weakness. Everting sutures are temporary. Weiss procedure provides durable correction. Cicatricial entropion requires posterior lamellar reconstruction.